Good morning. I am Professor Alex Demoule from Paris, France. The topic of my talk will be the bundles of care in the ICU patients. Here are my disclosures. My learning objectives will be as follows. First, how to prevent deep venous thrombosis. Then, how to prevent stress ulcer and in which patients. Which drugs should be used for sedation and analgesia and how to monitor sedation and analgesia. How and when to give nutrition. And finally, which fluid should be used with what targets. Let's start with deep venous thrombosis. COVID-19 patients are at high risk of deep venous thrombosis and subsequent pulmonary embolism, which is a life-threatening complication. This is due to the presence of major risk factors for venous thrombosis in the COVID-19. First, there is a marked coagulopathy. Second, because of the ICU stay and especially in case of mechanical ventilation, patients will be on bed rest for a prolonged period of time. Third, there is a strong inflammation in the COVID-19. Finally, two major comorbidities associated with the pathogenesis of deep venous thrombosis are present in the COVID-19, elderly age and obesity or overweight. The proportion of ICU patients with the COVID-19 that exhibit pulmonary embolism is extremely high, since it is estimated between 10 and 20%. Pulmonary embolism and deep venous thrombosis are associated with increased duration of mechanical ventilation, increased ICU length of stay, and increased hospital mortality. A prophylaxis of deep venous thrombosis is therefore needed in every patient. A low molecular weight heparin should be preferred, and the dose will be adapted to the patient's weight. In case of renal impairment, unfractionated heparin will be preferred to low molecular weight heparin. In case of high risk of bleeding, the interest of intermittent pneumatic compression is not demonstrated. Finally, in case of thrombocytopenia with a suspicion of heparin-induced thrombocytopenia, a non-heparin anticoagulant will be preferred. Let's talk now about stress ulcer. Critically ill patients are at high risk of stress ulcer. This is due to an imbalance between gastric mucosa injury and gastric mucosa protection. Gastric mucosa injury is increased by hypotension, hypovolemia, and systemic inflammation. Gastric mucosa protection is decreased by decreased bicarbonate secretion and decreased protective factors. In endoscopic studies, 75 to 100% of patients have mucosal injury. However, an occult bleeding is observed in 5 to 25%. Eventually, only 1.5% will present a clinically important bleeding. The risk factors for a clinically important bleeding are respiratory failure, coagulopathy, liver disease, and renal replacement therapy. On the contrary, enteral feeding seems to be a protection factor. It is important to understand that stress ulcer prophylaxis may have a benefit, but also some risks. Obviously, the benefit of such prophylaxis is to protect against clinically important bleeding. On the contrary, the risk associated with such prophylaxis is an increase in the incidence of infection and especially Clostridium difficile. In low-risk patients, there is no reason to give stress ulcer prophylaxis. But in high-risk patients, stress ulcer prophylaxis should be given, and in this case, proton pump inhibitor should be preferred. The risk factors for stress ulcer are mechanical ventilation, more than 48 hours, prolonged ICU stay, coagulopathy, 2 antiplatelet agents, occult bleeding, sepsis, high-dose steroids, and renal replacement therapy. In the intensive care unit, sedation is particularly needed in intubated patients. It helps tolerating the probe and artificial ventilation, and it improves patient-ventilator interaction. As any medication, sedation has benefits and risks. The benefits is patient comfort and the improvement of patient-ventilator interaction. The risk is an increased duration of mechanical ventilation. Sedation needs to be monitored. One of the most common tools to monitor sedation is the Richmond Agitation Sedation Scale. Here is how looks like the scale. -1 to -2 will define a light sedation, which is given to less severe patients, and -4 to -5 will define a deep sedation, which is given to severe patients. The target is initially, when the patients are severe, a deep sedation. Then, when the patient's condition improves and the patient becomes less severe, a light sedation will be targeted, and eventually daily interruption of sedation will be performed. Regarding the choice of the drug, propofol is preferred to midazolam. Sedation is given with an electric syringe pump. A sedation protocol should exist in every ICU. This protocol will include the choice of the drug and how to adapt drug dose to the sedation scale. In COVID-19 patients, sedation objectives can be difficult to achieve, and COVID-19 patients often require high dose of sedative. Other drugs may be needed and added. Pain is common in ICU patients. It generates anxiety and poor ICU experience. There is pain at rest, but pain is also increased during the very frequent procedures. In ICU patients, pain should be monitored either with a self-reported scale, such as visual analog scale in communicative patients, or using a behavioral assessment tool, such as the behavioral pain scale in non-communicative patients. Opioids are the key medication of pain in the ICU. In mechanically ventilated patients, opioids are given in addition to sedation. In non-sedated patients, analgesia by opioids is sometimes needed. Adjuvants to opioid therapy are used with the objective to reduce opioid use. Pharmacological agents that could help reducing opioid use are nefopan, acetaminophen, and ketamine. Non-pharmacological intervention could be also helpful, for instance, music, massage, and relaxation technique. Nutrition is a major issue in COVID-19 patients managed in the ICU. First, because of the high level of inflammation that COVID-19 infection generates, there is hypercatabolism, which increases energy and protein requirements. Second, prior to ICU admission, because of asthenia, anosmia, dyspnea, and confinement, many patients stop eating or eat less, with, as a consequence, a decrease in energy uptake. Therefore, when those patients are admitted to the ICU, they are at high risk of malnutrition. Finally, ICU patients are often immobilized on bed rests, which causes muscle wasting. For all these reasons, nutrition is a major issue in COVID-19 patients admitted to the intensive care unit. Therefore, nutrition should be initiated within 48 hours after intubation. There is no evidence for an earlier initiation of nutrition. Enteral nutrition should be definitely preferred to parenteral nutrition. Gastric nutrition is performed using a pump with a flow regulator. Patients in the prone position should receive enteral nutrition. Parenteral nutrition is used only if enteral nutrition is impossible or contraindicated. This is a case-by-case discussion. In every patient, physical activity should be promoted, and very important, nutritional support should be continued after extubation, which means that when the patient is extubated and leaves the ICU, the nutritional support should be continued. Let's finish with fluid control. Fluid control is a major challenge in COVID-19 patients, and it is very important to keep the balance. On the one hand, patients should not receive too much fluid because too much fluid causes edema, which impairs gas exchange and in turn can prolong weaning. On the other hand, hypovolemia should also be avoided because hypovolemia can contribute to the pathogenesis of acute kidney injury. Overall, in the COVID-19, fluid administration should be conservative rather than liberal. It is very important to monitor fluid administration with dynamic parameters. Finally, choosing the right fluid is extremely important. and it is very clear that patients should exclusively receive crystalloids, buffered or not. Hydroxyethyl starches, gelatin, dextrans, and albumin are not indicated. In conclusion, and these will be my take-home messages, regarding deep venous thrombosis prophylaxis, in all patients, prefer low molecular weight heparin and adapt the dose to the patient weight. Stress ulcer prophylaxis should be given only to at-risk patients and prefer proton pump inhibitor. Sedation is given to intubated patients. Propofol is preferred. Sedation should be monitored and should follow a local protocol. Analgesia include opioids, but other agents may help reducing opioid doses. Nutrition should be initiated within 48 hours, and gastric enteral nutrition should be preferred. Finally, regarding fluid control, a conservative policy is suitable. Fluid should be monitored, and crystalloids are definitely indicated. Thank you very much for your attention.